right, I think we'll go ahead and get started. Welcome, everybody. I'm delighted that you're here with us this afternoon for today's Hutch at Home series. And the topic is Health is an Issue of Social Justice with Dr. Rachel Ceballos. And I'm Jeannie Chowning. I'm the Senior Director of Science Education at Fred Hutch, and it's my pleasure to welcome you today. If you could take a moment and introduce yourself by adding your name, your role, and your school organization to the chat, we'll get a sense of everybody who's here. Sometimes we have folks who just find us in various ways, and it's nice to know who you are. So please feel free to drop that into the chat, and so we get a sense of the audience here. And during the presentation, if you could please stay muted, we'll address questions during the Q&A. Feel free to add your questions into the chat. And I can monitor the chat, and if there's a question that seems particularly relevant to what Dr. Ceballos is talking about, and there's a chance to kind of put it in there, I can elevate that for you. Sign up for our newsletter to receive news of upcoming events. So there's a little QR code at the bottom of that slide, and invite you to just sign up to hear more about what's coming up. Now, at the end of this presentation, I'll share with you what's coming up for the rest of the month, and also how you can find prior recordings. Okay. All right, so I'm delighted to introduce Dr. Ceballos. She's Associate Professor at the Cancer Prevention Program and Public Health Sciences Division at Fred Hutch, and studies ways to reduce health disparities in cancer, especially focusing on health outcomes in underserved communities. And that's some of what she'll be presenting today. So I am really delighted to turn it over at this point, Dr. Ceballos. And I will stop sharing.
Okay, and I'm going to try and share, and we'll see how that goes. Can you hear me okay now?
Yeah, it's great.
Okay, great. Slideshow from beginning. Okay.
There you go. All looks good.
Okay, great. So thank you so much for joining me today. I'm going to talk today about health as an issue of social justice. I'd like to begin with a land acknowledgement. I would like to respectfully acknowledge that the Fred Hutch was built on traditional lands of the Duwamish people, the people that are still here, and land which touches the shared waters of many tribes and bands, including the coastal Salish, Suquamish, Tulalip, Muckleshoot nations. We pay our respects to these communities, especially their elders, both past and present. And in addition to that acknowledgement, I put up a couple sites here. This one actually shows you, if you can see the cursor, the US and Canada site will, if you put in your area code, your zip code, will show you which tribal lands you are currently living on. And in our Seattle area, these are some of the organizations that help address some of the inequities, the needs of the local Native communities in Seattle. So I just wanted to highlight some of their work. I'm going to start off by giving you some of my background. This isn't something I usually do in my talks, but it's been quite a journey. And because you're working with high schoolers or our high school individuals, I thought that I would go ahead and share this. The first one is a picture that completely shocked my son. It's me in high school about 30 years ago and our little mascot back in 1990. When I graduated high school, I had a general idea of what I wanted to do, which was be an officer in the military. It was a way to get out of my neighborhood. I grew up in San Francisco. No one in my family had gone to college, but I wasn't quite sure how I was going to get there because I actually didn't do very well in high school. I was out of a class of 90, went to an all-girls Catholic private school. I graduated at about number 82. So the counselor said, you know, why don't you try a community college? I took a year off after high school and I joined the United States Coast Guard Reserve. I went to basic training, was in the Coast Guard for 8 years. and as a reservist, and did search and rescue and law enforcement there. But after my first year, when I came back from my training, I decided to go to community college, and because I still wanted to pursue being an officer in the service. And I started at a community college. I kind of found myself there, and I think being able to take some of the classes that I was interested in, I kind of learned how to seek out the areas of interest for me. I did not get into a four-year college, even though I applied in the beginning. But after 2 years at Skyline, I got into California State University, Long Beach in Southern California. And I continued in the reserve as I was going to college full-time, and worked full-time, nearly full-time, trying to get it all done. I studied psychology, and I thought I really, again, my only goal was to become an officer in the service. But in my senior year, I took a class on physiological psychology, on how the mind and the body interact. And in the 90s, this was an area of study that was really picking up as far as being able to tie it to scientific methods. So that was of great interest to me. I applied to one graduate program and decided if I got in, that I was also going to go into the Air Force as an officer. I had been accepted into a program for officer training program. But what happened was I got into San Francisco State University, into their physiological psychology program. And just to give you a little bit more background, I identify as Latina. I'm part of the queer community, and that was in conflict with the military service at the time under Don't Ask, Don't Tell. So I decided, look, I got into this program. I really think that I can do something with it. I'm very interested. So I went to the master's program at San Francisco State and spent 2 years there. I then decided that I resigned from the Coast Guard. I decided I wanted to go on for my PhD to do my own work. And so or to lead my own research. I got my degree in biobehavioral health. I mainly studied the effects of stress on biology. And what was really interesting was one of the things that got me into these programs was my service in the Coast Guard, and telling the story of how I found it interesting that even though we were all going to the same emergency, we all reacted in such different ways. Our behaviors were different, our physiological reactions were different, and that was absolutely fascinating to me. And that was part of my entrance letters for both of those, and I was told that that was really critical to my acceptance. I have a picture here of my son and I. He was born in Pennsylvania. He was adopted at 4 days old. He's now 16 and 6'4". I'm sorry, 6'6". What am I saying? I graduated after doing my dissertation in studying the effects of stress on immune and neuroendocrine function in both human and animal models. After that, I did my postdoc at the University of Washington, and that led me to the Fred Hutch. There I worked in a lab doing the biological samples, but met Dr. Betty Thompson, who's recently retired, phenomenon really in health disparities research. I had been told in undergraduate and graduate school that if I wanted to go into health disparities research, which I was interested in, growing up in Latino community, I saw quite a bit of disparities, but I was told you need to be a real scientist first, meaning work in the lab. So I did that. Betty took me under her wing, and I worked with her for 3 years, basically revamping how I did work from the lab, learning to work with communities, in partnership with communities, to be able to develop programs that work for underserved populations. After those 3 years, I received a faculty position at the Fred Hutch, and I've been a faculty member there ever since. I've been able to bring together my work studying the effects of stress and biology along with communities and developing programs for communities. And I want to talk to you today about why the work with community partners in public health is extremely important to address the issue of health disparities and health inequity. It's not just about the science and how quickly the technology goes, although that's absolutely amazing, but making sure that everyone has equal access to that so that people aren't left behind. So that's that background. I'm going to start off with a little bit of overview and some definitions just to make sure everyone's kind of on the same page. If there's something you'd like me to stop and talk a little bit more about, or you have a question, please feel free to put it in the chat, and hopefully Jeannie can point that out. You may already know, but I'm going to give a little bit of a background about the Fred Hutch. Its mission is to eliminate cancer and related diseases as causes of human suffering and death through prevention and curative treatments that are accessible to all patients. So the mission is inclusive of the idea of everyone having equal access to treatments. One of the things I want to point out is that it mentions prevention and curative treatments. So it's not just what is at the bench and what kind of treatments happen in the clinic, but also what are the things contributing to risk for health. The Hutch has been around 44 years, has nearly 3,500 employees, 16-acre campus. It's named after Fred Hutchison, the baseball player. His picture's up in the corner. I love baseball, so that's important to me. We have 3 Nobel laureates and 5 divisions: basic sciences, human biology, vaccine, infectious disease, clinical research, and public health sciences. And again, what I want to point out is that the Fred Hutch is inclusive of not only the basic sciences and lab-based sciences, epidemiology and computational biology, but health behavior and the psychology of health and the sociology of health. And that's a lot of what I'm going to talk about today, because health just does not just take place in the clinic. The official definition of health was defined by the World Health Organization back in 1946, and it actually hasn't changed. Health is a state of complete physical, mental, and social well-being, and not merely in the absence of disease or infirmity. So back in 1946, they were noting that health is not just the physical aspect. A lot of our medical training and medical practices now focus on treatment and just the physical. And I'll give a couple of examples of this later. What this framework, the socioecological framework, represents is that idea that health is not just in the clinic. Our health comes from multiple levels of influence on any one health outcome. This includes the individual level, what kind of knowledge someone has, their skills, their biology, the interpersonal aspect, what kind of social network do they have? Do they have social support? And what kind of support is that? Is it emotional? Is it practical for someone to get a ride to an appointment? Looking at the organization, what kind of institutions are surrounding the individual? Medical institutions, educational, physical activity. We'll talk a little bit more about that later. What is the cultural value and the norms? Is going to medical appointments something that is well accepted within the community? Is there some kind of belief that makes going to the doctor, or is there historical trauma involved in relationships with the medical institution that someone may not want to go to a medical facility? And also public policy. Let's think about the Affordable Care Act and what kind of state and local laws might influence people's willingness to go or financial ability to go receive medical care. All of these things influence individual health. Sorry, my dog's getting up because it's dinner time. We're going to try and hold them off for a bit. One of the things that I want to point out is that these things interact not just at one point, but over the life course. And over the life course, it can result in differences in health outcomes. So one of the things I want to point out here is a difference between the term health disparities and health equity. So I'm going to start with health disparities. Health disparities are adverse differences in health outcomes linked with social, economic, or environmental disadvantage. It considers the systematic factors as obstacles to health. So factors like, are there medical facilities in your region? Those are things that are obstacles to health. And when we're considering health disparities, we would look at the numeric value. How many medical facilities are there in your area? But one of the things that's really important is that health disparities is only a metric. It's only a number. So when we talk about health disparities, we're talking about what is the numeric difference between two groups. And in this particular case, a health-related difference between two groups. What is that numeric value? Health inequity or health equity is linked to disparities, but it's differences that are avoidable, unnecessary, and unjust. And this is where the issue of health as a social justice issue comes in. You may have seen this image already. What it shows is that inequity denies individuals the possibility of health. And if you look on the left here, the picture shows equality. If we gave everyone the same, not everyone would be able to achieve health, or in this case, watch the baseball game. But equity would be not giving people, everybody the same, but giving people what they need in order to achieve health. So it refers to the systematic injustice that results in a cycle of intergenerational inequity. The things that, if we can look at large group differences, the things that have contributed to generation after generation, not only at the individual level, but at the community level, at the policy level, how all of these things have unjustly contributed to differences in health outcomes. Back in 2008, an important document came out from the World Health Organization. And what it did was it brought to the forefront the importance of what we call social determinants of health. These are the conditions in which environments where people are born, live, learn, work, play, worship, and age that affect a range of health functioning and quality of life outcomes and risks. So why is this important? Because it includes the mental, the physical, the spiritual, and the social aspects that contribute to our resilience, as well as our vulnerabilities as individuals and as groups. The World Health Organization organized these social determinants of health into 5 broad categories. It is not an exhaustive list, and these categories are not mutually exclusive. But through decades of epidemiological research and research factors associated with poor health outcomes, they've identified these factors. And knowing these factors, being able to identify them, gives us targets as researchers for intervention to alleviate the health inequities. There are a couple of concepts that are important to consider. And I read that a new model is being proposed for the Healthy People 2030 that is more dynamic. And if you want to learn more about social determinants of health, um, looking at the Healthy People website is one way that you can learn more about the social determinants of health. One of the main things I want to show is that being able to alleviate health inequity requires a multi-sector collaboration. So people from different areas of research and social support and lawmakers as well as providers all need to work together in order for health inequities to really be addressed. And up until very recently, many of the studies were done just at single levels. So within a clinic, we're able to implement a particular intervention and it's effective. That's great. But what about the clinics who don't have the funds to implement it after the research is gone and the research is complete? It showed it was effective, but it's a multi-million-dollar study. So how is a federally qualified health clinic supposed to be able to support that intervention? And the other thing to realize is that within each of these categories are multiple levels of influence. And I'll talk about that in a second. Within educational access, we're talking about someone's health literacy or early childhood education, healthcare, provider availability, quality of life, distance to care services, neighborhood and built environment. Do people have sidewalks to go, exercise, go on walks, bike lanes, street lighting? What is the violence in the area? What is the police presence in the area? And what effect does that have? Access to nutritious food, racism, discrimination, historical trauma. What are the social norms? What is the civic engagement? And as far as economic stability, income, job opportunities, food insecurity, housing instability, poverty, all of these things contribute to health outcomes. And being able to address multiple levels of these at once is really where our public health research is now and needs to continue to build in order to address inequity in health. This particular image, this actually is a cancer survivor that our team has worked with. And as an example, one of the things that she experienced was from the prevention aspect around diet, because diet and physical activity contribute to risk of cancer. Her family expected her to cook in a very traditional way, which is not conducive to cancer. It actually can put you at higher risk for traditional, cancer risk. And when she tried to change things, it was not received well by the family. And there was a pushback against keeping things the way that they were used to. Physical activity. She lives in a rural area. There's no real safe way to go for a walk around some of the neighborhoods or on the roads nearby. At the time that she was doing this, they since have actually put in a road specifically for exercise. But at the time, she didn't have that. Early detection, having to drive multiple hours to get screening. Not only awareness of screening, so our team has done a lot of education around prevention and early detection, and showing people where they can go to get screening, but at the time it was very far-reaching areas. Going to diagnosis. Most of my work takes place out in Yakima Valley. And if there are specialty providers that are needed, there's no one nearby who can address their specific issue. So sometimes they're driving 3 hours one way for not only diagnosis, but also treatment. And after cancer treatment, going back and forth for radiation is not only expensive, but time consuming and exhausting. It's not conducive to positive outcomes. There have been a number of studies that have shown that in certain ethnic groups, like African American and Latino populations, misdiagnosis because of an experience of the provider, or a poor quality of treatment because of very poor resources, is very strongly linked with ethnicity. And so the cancer outcomes can be much poorer. I'll talk about this in a second, but as far as survivorship is concerned, although 70% of the population that out in Yakima Valley where I work is Spanish speaking and identifies as Latino, there were no Spanish language survivor support programs out in that region. And when I checked here in the Puget Sound, there were no Spanish language survivorship program. The only one that we know of now is actually delivered by someone that we trained in our program in this area. So, and the issue of end-of-life care is just emerging now, and how to address that as an equity, especially as when we're talking about cultural differences. So this is how the additive effect of health inequities can occur because of those multiple levels of influence through the social determinants of health. Oh, such as access and cultural factors and the built environment. One of the things I'd like to point out, this is a model developed by the University of Wisconsin Population Health Institute in collaboration with the Robert Wood Johnson Foundation. And it delineates the underlying modifiable determinants of health and groups them into four main categories. Though it's understood to be a really important predictor of health, genetics is excluded from the model because it's primarily at present non-modifiable. But if you look, one of the things that's really important when you look at the things that influence health is that clinical care, access to care and quality of care, only accounts for 20% of overall health outcomes as measured by length of life and quality of life. The rest, physical environment, 10%, social and economic factors account for 40%, and health behaviors account for 30%. So one of the things about the United States as a whole, and why our health outcomes are much poorer on an international level compared to some other countries that may be really surprising, is the fact that we focus so much of our healthcare funds on the clinic. This is a healthcare expenditure scale from the Brookings Institute, and it shows a number of countries, France, Sweden, Switzerland, Germany, and the US. And what it shows is the amount of funds, percent of fund of the GDP that is spent on healthcare versus social care. So providing services, social services, and providing preventive care and focus on diet and physical activity. If you look at health services versus social services, the average from the overall group for each dollar spent on health services, they spent $1.70 on social services. But the US, for every dollar spent on health services, spends 56 cents on social services. And we think that this is a major contributor for why we do have such an overwhelming chronic disease, diabetes, heart disease, and cancer compared to other countries, is because we focus more on the clinic as opposed to preventative and aftercare services that are more socially focused. So what do cancer health disparities and health inequities look like? I'm the program lead for rural health at the Fred Hutch Office for Community Outreach and Engagement. And so I'm going to show you a little bit of data that we have here, US-wide, rural versus urban. If you look here, we have rural incidence versus urban incidence. And on average, the incidence of cancer, all sites, is actually higher in urban areas than it is in rural areas. The mortality, however, is higher in rural areas than urban areas. And when you look by men and women, there's actually a significant difference here between rural and urban women. You can see quite a difference. And this value between 218 to 200 is quite significant as well. The reasons behind this are related to the social determinants of health. So being able to find interventions that work for the community that will address these issues, these differences in numbers, is extremely important. The things that contribute specifically to health inequity in rural areas, high rates of low to moderate income, high rates of low education, higher rates of uninsured individuals in rural regions, less employer-sponsored health coverage, more likely to be a beneficiary of Medicaid. And recent data show that 2/3 of uninsured in rural areas are in states not implementing the Affordable Care Act Medicaid expansion. Workforce, healthcare workforce. 8% of all physicians and surgeons choose to practice in rural areas, and workforce has less education and fewer specialties and subspecialties. So as I was saying, having to go out much further to get specialty care. One of the things the Fred Hutch is doing is trying to build a network with rural federally qualified health centers to provide virtual specialty care to patients and assisting their providers with rare cancers and ensuring that accurate not only diagnosis but treatment plans take place. Looking again at rural versus urban health behaviors, there's, if we look at the large metro center versus the smaller metro micropolitan non-core areas, there are a number of things that contribute to prevention of cancer. Current non-smoking. It's actually interesting, the large areas, metro areas actually have larger non-smoking than the rural areas. Maintaining normal body weight. It's much lower in the rural area than it is in the metro area. Same is true for aerobic activity. And the number of people that report 4 or 5 of these health-related behaviors is lower in the rural area than it is in the large metro areas. So the number of people that are engaging behaviors that are protective is overall much lower in the rural area than it is in the metro area. And that can occur because of education, as we talked about, access, or social norms. I'm going to talk very briefly to show you some of the data specific to the Fred Hutch catchment area, which is the 13 counties surrounding King County, including King County. In this region here, these are the urban areas, and this is all of the rural area in our catchment area. So some of the data that we looked at not only looked at rural versus urban differences, but looked at something called intersectionality. You might be familiar with this, but it's the interconnected nature of social categories such as race, class, gender, as they apply to given individuals or group. They are overlapping and independent systems, often of discrimination or disadvantage. And so when you look at someone who is in a specific area, or urban versus rural, there may be other factors that put them at even greater risk than just being a member of the rural or the urban community. So for example, here we have, let's see if I can get the cursor over here, in breast cancer, which is the main area that I work in. Yellow here is the small rural towns versus the urban towns. Now, again, as you saw in that previous slide, the rural areas actually have lower incidence of breast cancer overall. But when you break the size of the town down by race, ethnicity, you can see a tremendous difference in the Black African American community, where there is a much higher risk compared to the rest of the rural population. The reasons for that are many. It can be everything from biological vulnerabilities, although the data is unsure about that, but largely has to do with the interactions with the medical system, historical trauma, access, financial access to providers. And that is the case pretty much in all of the suburban, large town, and small and rural town in our catchment area. When you look at mortality, the American Indian and Alaska Native community for breast cancer is at very high risk, where the rates of cancer are extremely high in the small towns. This is something that we are working with the Yakima Nation. We are trying to conduct a needs assessment. Right now, we had to put our needs assessment on hold for COVID, and we were doing a COVID study with them. And we are going to be going back in the next couple of months to begin looking at cancer and how we can not only do more education, but help improve access within these populations. So how do we try and combat cancer health inequities? One of the first things I learned from Betty was this image, and I think that it's a great visualization. For fair selection, everybody has to take the same exam. Please climb that tree. Now, obviously, not everyone is going to pass this test. So traditionally, researchers had found that one intervention worked for a community. So they would take that intervention and try and deliver it in another community. However, when you think about the fact that resources differ within communities and social norms differ within communities and social support and resources are different, you cannot implement the same intervention. And as I mentioned before, one of the faults of scientists has traditionally been delivering an intervention that's effective and then leaving the community and not leaving them with any resources. So one of the things that I have found and that the research is in strong support of is the idea of community-based participatory research, which is a strategy of research that breaks away from that traditional practice of we know best. And this is a South African quote, "Nothing about us without us is for us." And that's the idea behind community-based participatory research. It's a collaborative approach that equitably involves partners in the research process, recognizes unique strengths that each contributor brings, and it begins with a research topic of importance to the community, has the aim of combining knowledge with action and achieving the social change to improve health outcomes and eliminate health disparities. And this is a definition from the Kellogg Foundation. I just realized I didn't put that on there. One of the ways that we have done this was started, this strategy was started by Betty Thompson over 20 years ago in the lower Yakima Valley. And the Fred Hutch actually has a satellite office in the lower Yakima Valley. These are our staff members. They've been there a minimum of 16 years working in the community. They live in the community. We have a community action board of anywhere from 22 to 25 individuals that range from the radio station to medical providers and religious representatives in the lower valley. So here we have in Seattle, the Fred Hutch. It's a 3-hour drive to our satellite office, but this lower valley region here is one of the primary agricultural regions in the state. A lot of the Latino population, the majority of the Latino population in the state live there, and a very large Native American tribal lands of the Yakima Nation are there as well. In the last few minutes here, I want to give you an example of how we kind of pulled out some of the data and found out one of the social environmental things that influenced cancer outcomes in cancer survivors. So as part of our community advisory board, we had been hearing that there were survivors who did not know that other people had cancer in their community. They felt extremely isolated, and they felt that once their cancer was over, quote unquote, that they should be back to normal. And the normal that they were thinking of was the one before their cancer diagnosis. There weren't any, as I said, Spanish language resources. And we reached out to these individuals. Some of my colleagues did qualitative research and identified what some of the concerns were. And then I built on their work and created a 10-week Spanish language program for cancer survivors that looked into stress, talked about diet, physical activity, mentioned how to talk to your provider, the importance of talking to your provider. Our lay health workers, their community health workers that were in those pictures, they were the ones that delivered the intervention. And this was something that they weren't used to doing, actually running support groups this way, but they did a fabulous job. We put people either in an immediate support group or a delayed support group, so everyone had a chance to be a part of the support group. We looked at stress and quality of life, social support, and also measured some biological factors. As I said, my work kind of all came together, focusing on health equity, stress, and biological impact. One of the things I want to point out is that these studies always take place in 3 phases. So here, phase 1, we would do a needs and resource assessment. And that influences how the intervention is designed. So for example, talking to your provider, there's a concept in the Latino community of a deference to authority, and physicians are part of that. So it would be considered rude to ask a question of someone who is a respected professional. And what we did was have them rehearse and have our participants rehearse asking questions and framing it as the provider can provide you better care, give you better care, and that's what they want. They will give you, they will appreciate if you ask questions and share your concerns with them. And that reframing actually was well received by the participants. We tested them at baseline, 3 months and 6 months. And then once the intervention was over, those in the immediate group, we conducted another qualitative follow-up to ask them, how was the intervention? What didn't work? What can we do better? And these studies are done in collaboration with the Community Action Board. We share all of the data with them. We are then able to not only get the participants' feedback of their experience, but how do we tie in these interventions to the systems already available in the community. We kept this a very financially, not so burdensome program. We had everything on paper, not just PowerPoints, because sometimes we would go places where there were no PowerPoint or computer available to hold the groups. we're able to train people in the community to run these groups and set up networks of support for them so that the groups can continue after the intervention is over. And this particular study had some interesting findings. One of the things I want to say is that I was focusing on stress. Stress was actually not reduced in this group, and that was really disappointing. But after talking to participants during the phase 3 qualitative assessments, we heard a lot about stress outside of the family, outside of cancer, that contributed to the high levels of distress that we were seeing. And that is a possible reason why we did not see a reduction in stress. Luckily, we had included a stress measure, the Hispanic Stress Inventory, and it measured not only interfamilial stress, but extrafamilial stress, meaning discrimination and mistreatment perceived outside of the family from the larger social environment. One of the things I want to point out here, when you look by language, people who preferred English or spoke English as well as Spanish versus Spanish only, you can see the emotional well-being scores, this is a quality of life measure, actually decreased. So cancer-related emotional quality of life was lower in people who spoke Spanish only compared to those that spoke Spanish as well as English, or English better than Spanish. And it was not statistically significant, but it was close. We do see a trend there. And there wasn't much of a difference. There's a little bit of a difference. It's kind of a U-shaped here in interfamilial stress. But what was statistically significant was the level of extrafamilial stress. And you'll notice that it goes from 1.45, 1.5 to 2.74. And in psychosocial circles, when you can, this is called the standard deviation, which is the spread, the distribution. If you can change a score by a half a standard deviation, that means that it's clinically significant change. Sorry, I'm turning it off, but it keeps going off. It is a clinically significant change. So this is a significant increase in the amount of stress that people who are Spanish speaking only are perceiving. And that goes along with what the qualitative data was showing us. So one of the things we wanted to do was look at whether or not extrafamilial stress was related to their language spoken as a proxy for acculturation and emotional well-being. And we found that there was a significant relationship between the language spoken and emotional well-being, such that emotional well-being was lower in those that spoke Spanish only. We looked at language and extrafamilial stress. We know that it was higher. And then we looked at whether or not extrafamilial stress, when put into the model, changed the relationship at the bottom. And what we found was that the relationship between the language spoken and emotional well-being actually went away. What that means is that the influence of extrafamilial stress was such that it was so strong that it is the pathway by which acculturation or language spoken affected emotional well-being. So this is a very clear example of how the external factors are, external social factors are impacting the quality of life of cancer survivors. And these are cancer-specific quality of life measures. So it's not just general quality of life, it's specific to their cancer experience. So the next step of our study are to conduct an adaptation of a Spanish language stress management program that's already been shown to work in the urban Latino community. We have several projects that we are currently adapting from the urban community to the rural community. I'm happy to share some of our experiences with that adaptation and how we're progressing on those. We're working very hard with our community partners to deliver the intervention as equal partners in the process. One of the things that we are talking about is including civic engagement training to address policy-related factors. And this training program is actually one that is from a community partner that they developed and have been delivering in the community for over 15 years. So it would be wonderful if we can put our research-based program together with the civic engagement program and have a true collaboration and partnership testing how well these work together to address multi-level influences on health. We are working very hard at the Fred Hutch to build a larger cohort of researchers and community partners that understand how to work together, that speak a similar language, that know which questions to ask, which are important to building relationships, sustainable relationships, because that's the goal of community-based research, is not only building sustainable programs, but sustainable relationships. And then institutionalizing the practice of community-engaged research within our academic organizations, meaning making it a standard of practice, not something that's the exception, so that when we have our lab scientists develop these incredible treatments, how do we make sure that they get to those that are underserved or those in marginalized communities? So in summary, I think this is a great image. We're all in this together. I'm sure glad the whole isn't on our end. Obviously, eventually it's going to get to their end. We all need to work together to address the emergency at hand. And whether you're talking about the public health issue of racism, discrimination, or you're talking about gun violence, or you're talking about lighting on the street, all of those issues are related to people's and entire communities' health outcomes and the disparities that we have seen and that continue over and over again, decade after decade. We have to interrupt the systemic injustices of services, policies, social discrimination in order to address health inequities and make sure, as the World Health Organization tried to make clear, that everyone has an equal right to health. We need to do this purposefully through collaboration and multi-level, not just working at the individual, but organizational and policy levels together to create a much greater impact. That's what's required to address overall population health disparities. And that is the end of my talk. Thank you very much for your time and for listening. And I'll stop sharing.
Wonderful, thank you so much. And we have an opportunity for Q&A now, and please join me in sending some appreciation to Dr. Ceballos through your reactions or in the chat. And we'll take questions now too. So I invite especially the students who are here with us, if you have a question, we'd love to hear your questions.
I just realized my camera's been off. I'm sorry, I don't know what happened. It disconnected, so.
No worries. So, you know, I appreciated where you ended up with this talk in talking about, you know, the need for us to recognize unjust distribution of resources and discrimination and racism. And I think, you know, to name that especially is important when we talk about the extra familial stress, right? And especially in light of what we are seeing happening across different communities of color. extrajudicial killing of Black folks and Asian American, violence against Asian Americans, and all these different issues that people are unjustly having to kind of navigate. Right? Like, so when I guess my question is, when you're looking at extrafamilial stress, what kind of questions do you ask about that, or how are you getting it? What are the components of that you're putting into your kind of research model?
Well, we're asking questions about their experiences and how they're treated in the general community, whether they're treated differently than others, as well as within the healthcare setting, and ask them specifically, because of your race, ethnicity, do you feel that you are treated this way? And that's the framework that they're using to respond to the questions about various scenarios of discrimination.
Yeah, because I think, thinking back to the picture of the kids on the boxes or people on boxes, like, I think, equity, we can think even more about, like, what does it look like without the fence, or what does it look like if those people are playing the game, or they're on the, they're in the bleachers instead of, outside of the game, right? Like, and so how.
Yeah, there have been updates on that image, actually, and one of them is where there's no fence at all.
Right.
So that's what, the authors of that said was the ultimate goal.
But I think, your work with the community health folks that are in the Valley, from the community, working in the community, is a great example of how to bring people into this work and to value the knowledge in the community. So if we have a few questions, so is your intuition experience that affected groups have a pretty good sense of the factors that are responsible for the disparities they experience? That is, do they know what the main problems are that they face?
Yeah, I think so. I think that they do have a pretty good sense of it. And some of the parts where we might come in as researchers and help when we're talking about the clinical setting as well is with the language and trying to explain to both sides some of the cultural differences that we see. That's why we do the qualitative work, is to really get at the hows and whys people do certain things or don't do certain things, or what might help, what might not help, and presenting them with scenarios of options on how to respond to something. So really talking to them. And we want to be culturally humble and understand the community's perspective, so that we can develop interventions that work within the community's social norm. So it's really our job to adapt to their community's norm and the community's resources. So listening is a big part of it. And, we can't say, we've had some extreme examples, people saying, I got cancer because I got hit in the breast, or I got cancer because I committed a sin. I'm not going to say, no, you're wrong. I'm going to say there might be these other things that contributed to it. But, we have to be very cautious about respecting their cultural beliefs as well. So that's where the first part of really listening to the community is extremely important, and having people who know the community, like our staff out there, and getting people who are advocates for the community on our board to say yes or no for something is extremely important. And one of the things we're trying to teach some of the researchers now is getting the input from the community before the grant goes in. So before you design your study, you should be getting the community's input so that it influences the study design before you even apply, instead of doing it afterward, and placing the community partner on an equal level with the researchers, because they're the experts in their communities. We need to understand that we do not know everything about, especially about marginalized communities.
Thank you for that. That was a great response. This is something I'm interested in too, Joan's question, because we're both working on some curriculum that kind of addresses this question. But how do you respond to people who first assume that genetics is the cause of disparity?
That's from Joan. Hi. I often respond with, I don't know. I don't think we know that yet. You know, that most of genetics, and correct me if I'm incorrect, Joan, but most of genetics may put you at higher risk for something, but there's no definitive, or there's very few diseases where things are definitively, you have this particular genetic makeup, you're going to get this disease. There's very few diseases where that happens. You may be at higher risk for something. It may be at a vulnerability because of some genetic makeup, but there's many other things. It's a very small percentage of the actual health. And when you're talking about health behaviors and environmental factors, that actually is going to be a greater influence on overall health. But Joan, if you'd like to add anything to that, by all means. So that's kind of my general response. When we talk about health disparities specifically, I come back to the issue that race is not a genetic attribute. It is a social construct. And that is the biggest factor that I bring up when we're talking about racial ethnic disparity specifically. You know, because there's the individual, you know, if you're doing rural urban, that's one thing, but coming back to race being a social construct.
Very good. What other questions do people have? Oh my goodness, look, are we out of time already? Wow. I was just like so into it. Like usually I'm like, okay, we're gonna wrap this up. Thank you so much for being willing to share with us today. This is fantastic. I have just a few closure slides, so if everyone can hang in for just 2 more minutes here, because we want to get your feedback, because this is so wonderful. We want to capture some of this in our survey. So if you have a moment to complete just a very short couple question survey that helps us kind of report about how things are going with this effort for Hutch Home. So I'll put this also in the chat. And that's a QR code you can grab with your phone. We have recordings and schedule at the SEP events page. So also we have a YouTube SEP channel, which has recordings. This has been recorded, so we'll post this at some point. Our next virtual field trip is 4/27. So our field trips and talks are always Tuesday at 4 and usually 2 weeks apart. So virtual field trip is in Dr. Edith Hootie Warren's lab. And he's contributed to the development of adoptive T-cell therapy, but he's also the head of the global oncology program at Fred Hutch. And so it's been a lot of fun to do the virtual field trips and see what the labs are like and get to talk to different people in labs. So hope you can join us for that as well. And with that, we'll be signing off. I'll stay on for a few more minutes in case anybody wants to chat, but thank you so much for being with us this afternoon, and hope to see you again all shortly. And thanks again.